Just a minute, sir. We are just checking it because it takes around 30 seconds. One moment.
It's showing live streamed.
Namaskara, Ravi. Ravi
Sir.
Kulkarni and Ravi from Minto and Navneet and
Namaskara,
Raksha.
sir.
All
Thank
welcome.
you, sir. I think
Welcome
we
to
are
this.
live now.
Yeah, we are live, ma'am. We are
We're
live.
live.
Yeah.
I welcome everybody to our beautifully curated CME on mastering macular disorders. And we wanted this to be something that everybody can benefit from. So we've mostly directed towards it being a practical guide, not only for budding retina surgeons, but also for a practicing ophthalmologist or a practicing general ophthalmologist. And we have some really great topics and really great speakers as well. And I'd, of course, thank KOS for this wonderful opportunity, and also Micro Vision for, putting all this together. I'm having a little trouble with my PowerPoint. Just a minute. Yes. So thank you, Microlabs Vision and Karnataka Ophthalmic Society for this wonderful collaboration and for having this meeting for all of us. And we're very happy to have with us today Dr. N.S. Muralidhar, who will be sharing pearls regarding management of retinal issues. He's a very senior doctor and we all look up to him. He's not only a gold medalist from AIMS and he has a fellowship from Sydney in Vitreoretina, but he also started an iconic institution in Karnataka, and we all knew it for their wonderful retina work. So RIK was started with Dr. Hemant Murthy, and he's held multiple positions, including being the former president of KOS, former president of VRSI, and he's currently the president of Karnataka Retina Society. A warm welcome to you, sir.
Thank you very much. Thanks, Soumya, for involving me.
Thank you, sir. I'm Dr. Soumya Nanaya. I'm a scientific committee member at KOS, and I'm very glad to be here to be a part of this wonderful webinar. We also have Dr. Ravi Kulkarni, who will be co-moderating the session with me. He is a practicing doctor at Rani Benur, and he has 24 years of experience, and he is also a member in our scientific committee this year. Dr. Vinay is currently working as an associate professor at FFMC Mangalore, Father Muller Medical College, and he has special interest in ILM peeling in detached retina. Dr. I think Naveen Nayak is a very senior doctor. I have known him for many years, and he's a fantastic surgeon as well. And so a warm welcome to you as well. We will start with a presentation from Dr. Vineet, as he would like to attend to some other prior commitment that he has. I'll just start with his CV. Is this visible? Is Dr. Vineet's CV visible? Yeah. So Dr. Vineet is a VR and phaco surgeon, and he practices at Anugraha Eye Hospital, Kalburgi. And he has a very interesting case to share with us. So over to you, Dr. Vineet.
Yeah, thank you, ma'am. Is my screen visible, ma'am?
Yeah,
Yes, make it big.
Yeah. Good evening, everyone. First, I would like to thank Karnataka Ophthalmic Society and Dr. Soumya for inviting me for a talk. So today I'll be talking about two cases. Basically, it's a CRVO, one needing one injection and another one is an anti-VEGF dependency. So this is a case one where a 13-year-old female presented with complaints of sudden diminution of vision in the right eye since 6 days. No similar history in the past, no history of trauma, no significant medical history. On examination, right eye visual acuity unaided was 6/60, color vision was abnormal, and contrast also was 25%. RAPD was there, no NVI. And whereas left eye vision was 6/6, and anterior segment and posterior segment was normal. This is a photo of both the eyes. So coming to the right eye, in this right eye, as the fundus shows, there is a disc edema and dilated tortuous vessels and multiple flame-shaped hemorrhages. On OCT, we can see a cystoid space along with the subretinal fluid. The visual acuity at this time of presentation was 6/60 parts. So patient was sent for investigation as she is a young girl. CBC, ESR, C-reactive protein, RBS, FBS, PPDS, lipid profile, serum homocysteine, serum creatinine, carotid Doppler, all of which was turned out to be normal. Actually, this patient was sent by a rheumatologist. She went to the rheumatologist with a joint pain. Even they have done a profile, complete profile, which was normal, but she complained of diminution of vision. She ended up with a CRVO. So we gave an injection of ranibizumab in the right eye. This was the OCT and the fundus picture of post of 1 week, where the hemorrhages started reducing. Disc blurring, disc edema was reduced. And on OCT, we can see that the cystoid spaces have gone, but the subretinal fluid is persisting at the end of 1 week. Visual acuity is 6/24. And at the end of 1 month, visual acuity improved to 6/18, and the fovea looks dry. And here on the fundus examination, the hemorrhages have resolved, and fovea is dry, and vessels still are dilated and tortuous. Disc is now a little better visible. So at the end of 2 months, patient regained a visual acuity of 6/6. Sorry, this was taken in a different center at our hospital. Fovea looks completely dry. Still, the disc margins are clearly visible, vessels are dilated and tortuous, and there is no macular edema. So this patient needed 1 injection to regain a vision of 6/6. This was day 1, 1 week, and 1 month. So coming to the case second, a 70-year-old male presented with the complaints of sudden diminution of vision in right eye since 10 days. He was a known case of type 2 diabetes and hypertension since 10 years. He also has a heart disease for which he is on blood thinners. On examination, right eye unaided visual acuity is 6/36, BCVA 6/18. Left eye is 6/60, 6/24 BCVA. Anterior segment shows PCIL, and in the left eye, he had a NS4 cataract. So coming to the fundus examination, in this case, the left eye, I'll finish up first. Patient had a NS4 cataract, whether the fundus appears normal and OCT is normal. Coming to the right eye, on examination, this patient had a PCIL. Here we can see a disc, there are hemorrhages on the disc and a dilated and a tortuous vessel, along with multiple flame shape and dot hemorrhages. On OCT, here we can see a multiple cystoid spaces on OCT, but no subretinal fluid. Visual acuity at presentation is 6/36. So on investigation, his sugars were high. He was having a sugars of around 300. And he was sent for carotid examination, where 70% stenosis of right paroxysmal internal carotid artery was seen. OCT and CME and CRVO. Patient was sent for cardiac opinion as well as to control the sugars. Patient returned to us after 1 month with the same persistent edema. So after the fitness, we have given him an injection of ranibizumab. And this was post 1 week of injection. There is a reduction of hemorrhages, and so edema started decreasing. Patient has a vision of 6/24. So and at the end of 1 month, fovea looks dry, vision is 6/12, and the hemorrhages have decreased, and disc margin also is clear. This is day 1, 1 week, and at the end of 1 month. So we thought that fine, at this 1 month fovea is dry, we can keep the patient on follow to look for any ischemic changes like neovascularization of the disc or iris or elsewhere. So patient came after 1.5 months saying that his BP shoot up, and he came for examination. He says his vision is little blurred. So on examination, we found a NVE in the right eye. So I did a pan-retinal photocoagulation for the patient, and he was kept on close follow-up to detect for the neovascularization. At the end of 2 months, the patient came for follow-up 15 days later after the laser. He has a cystoid macular cystoid spaces in the fovea, and complaints of diminution of vision. Vision was 6/18 partial. So this patient, as his sugars were controlled, BP was controlled. So we proceeded ahead with the second injection. So to summarize, this is a patient who has a systemic comorbidities like diabetes, hypertension, and also on a blood thinner. And in between had a spike of high BP. So in CRVO, we need to remember that don't judge CRVO by first response. Monitor for ischemic changes as well as the systemic trigger factors. And a quiet macula today doesn't guarantee a quiet retina tomorrow. CRVO needs follow-up and not just treatment. Yeah, thank you.
Thank you, Dr. Vineet. That was quite concise, and also you gave us a good takeaway point from that. Muralidhar sir, would you like to add anything to this?
Thank you, Vineet. Two good cases for starting our discussion. The first case is a 13-year-old girl.
Yes,
And a CRVO in a 13-year-old girl is very unusual. And this is not like a regular CRVO that we see in our day-to-day practice. So this patient also was under the care of a rheumatologist. So I
Yes.
think in this particular girl, there was a very strong systemic factor. Although it has been worked up, nothing has been found. I think the story is not yet over. So we need to actually look at various other parameters. I don't know what rheumatologists, what all they have done in this, what workup they have done. But in a case like this, we have to look for hypercoagulability states. We have to look for, autoimmune disease. We have to look for many more antiphospholipid antibodies or even protein, C protein. Yes, I think some more workup is needed because it's very unusual for a patient like this to get 6/6 in 2 months and then become normal. I think we just have to follow up this patient quite, in detail. Probably the only follow-up will tell. So
Yes,
if CRVO in young is definitely something that we need to investigate much more. If a 60-year-old man comes with CRVO, we may not really investigate very thoroughly, other than making sure that his hypertension, diabetes, and maybe lipid profile. And, another thing which was interesting was the carotid studies. Normally, we don't order carotid studies in a patient with CRVO because it's more done for a CRAO. For a venous occlusions, carotid Doppler studies are probably not done as a routine, but maybe it is a standard practice in this one. The second patient looks like a typical CRVO. I was quite interested. You said that the patient developed NVE, which is again not common in CRVO. Was this actually diabetic retinopathy itself?
Yes,
Was
sir.
it
But
combination
in
of
other
CRVO and DR? What is the other eye
Because
status? We don't know because
other eye
it has
is normal,
nuclear
sir.
sclerosis 4+, so
Yeah.
we don't know whether the other eye has any diabetic retinopathy.
Yes.
So interesting cases. They responded very well to anti-VEGF, but still the story is not over. As you said, they need to be followed up. And NVE developing within 1 month after in a CRVO is very unusual. We all know that it's typically 2-3 months later that they develop neovascularization. It's very unusual. So I'm wondering whether there is an underlying diabetic retinopathy component in this patient.
Yes, sir. Patient first visit when he came, he had a macular edema. And he says for more than a month, he had a decreased vision. To control sugars, he took 1.5 months. And then he turned up for injection. First injection.
I'm definitely wanting to listen to others, what they think. And, so it's very important to know that these are just not one-time treatment diseases. That's important. That's what, as you have emphasized in your last slide, a dry macula at the end of one injection doesn't mean anything because it may be few months down the line that the patient is going to develop another recurrence of macular edema and they need to be followed up. And that's what you have to actually, most important is a patient education, because if a patient is not told from the beginning that he will need the injections on a regular basis for some time, then otherwise they might be very unhappy.
Dr. Naveen, would you like to add something?
Yeah, as Sir mentioned, very interesting. I think one of the main in the kid, yes, especially, and we luckily once I've moved to Manipal, I'm seeing lot of systemic autoimmune conditions leading to these kind of picture. especially in younger patients. So yes, as sir mentioned, I think I would be really keen on antiphospholipid antibody. Very commonly missed, but again, considering the age group, very, very important. And in the older patient, yes, I think the carrot, one of the reasons why the patient must have had an early neovascularization is the alongside the arterial ICA
Carotid
occlusion.
artery stenosis of 70%.
Yes.
Yeah.
So that is one of the reasons I think good that it was done. As sir said, don't normally do it, but ever since I've been working with Dr. Nitin sir, all CRVOs we invariably off late, like last 4 years, we're doing carotid Dopplers. But yeah, very rarely do we pick up this. But whenever picked up, we know how to kind of probably see them a little more in quicker succession rather than miss. Like normally, if a CRVO is resolved, we would call them only in 2 or 3 months when we expect NVG. But yeah, once you have a vascular occlusion alongside, so better to see them a little early. Nicely presented, Vineet. Thank you. Thanks, ma'am.
Thank you. Thank you,
Thank you,
Dr.
thank you,
Naveen.
sir.
Thank you, Dr. Vineet. And thank you for making time irrespective of
I have
other
a question.
commitments. Yes, sure. We can take one more question, but then we will move on to the next talk. We'll
Sir,
take your question.
other than these, what are the routine tests? Is there anything investigations we have to add in these?
Actually, Ravi, I was about to comment on the same. Like other thing, the first 13-year-old anyway rheumatologist is seen, he would have definitely done. We need always female child, always ask a leading question for any hormonal therapy. There are many reasons for which to delay something or early onset. Sometimes they can be put on these kind of a therapy, which they usually conceal, they don't reveal it. Okay, that is one thing we need to rule out. And autoimmune children, it is known to be negative, and over a time, it can, turn out to be positive. So that is something is important. And the second thing, from general ophthalmologist point of view, what I strongly want to convey is, please don't miss doing a conioscopy in all this vascular occlusion in every visit, because sometimes, anterior segment neovascularization may precede the posterior segment neovascularization. That should not be missed, because we retina specialists, we tend to ignore it, especially multispecialty with glaucoma. So that is, please, if they follow, make sure before dilatation you do a gonio and then dilate. So these are two things I just wanted to add.
In complete hypercoagulable state like factor 5, protein C, protein S. And since he's visiting the rheumatologist, then the GIA has to be ruled out, sarcoid. Any of these kind, I think it's mainly a systemic disorder which is leading to it. A little more detailed blood workup, I think, should reveal something.
As NSMs are told, this guys is not complete. We need to still, follow up this.
Dig into it more.
Thank you. We'll move on to the next talk, and maybe in between we can also take some audience questions if we are presented with any. We next have Dr. Srinivas Joshi. He is well known to most of us. He has completed his fellowship in VR surgery from University of Toronto in North America. And he has recently also completed an executive MBA from IIM Calcutta. He has many publications, many presentations, and he's also very active at the All India level. So a warm welcome to you, Dr. Srinivas. And I'm going over to you for your talk.
Thank you so much, Soumya madam. Thank KOS, all the office bearers, and Dr. Soumya for inviting me for this the first webinar of this season, madam. If I'm not wrong, after the
Yes,
new
first-
office bearers got elected.
Third one, but first retina.
Yeah, first retina. Okay. Yeah, thank you. So, good evening, everyone. So I hope my screen is visible.
Yes.
Yeah,
Make it full screen, sir.
it is full screen. No?
No, sir.
It's not on slideshow yet.
Slideshow.
1 second. Share it again. So,
Are you using a Mac?
no, sir. Now is it visible?
Not
Yes.
yet.
Yes.
Yeah,
Yes.
yeah,
Yeah,
this is fine.
Okay. The topic given to me is approach to a patient with a decreased central vision. So let's come to a little bit of what we need. The whole story, say, for example, a 67-year-old male, NS2, mild distortion, 612 vision, and then what we do in these kind of cases. So the most important thing is do a posterior fundus evaluation. And when you see something that the FR is dull, then you use the 78D or the 90D to see what is happening over the macula. Whether it's a macular hole, commonly you can do a Watsky-Allen's test to find out whether there is any distortion or whether there is gap in between the slit which you throw, what kind of distortion you have. So the most important here is, say, for example, talk about the unhappy 6'6" patient. Snellen's measures the quantity of the vision, but the macula dictates the quality. So if a patient complains of a wavy lines or a missing letters, it is most commonly a macular problem until proven otherwise. So we are now going to cover how to triage these patients in this 8 minutes of talk. So decreased central vision, what are the causes? Either it could be a macular, optic nerve, or the media related. Whether it is urgent, so not every blurred vision is benign. So clues suggesting to a macular source, patient usually complain of curvy or metamorphopsias or micropsias, scotomas, and difficulty in reading. That is very important. No pain, almost no pain or very little pain. Color desaturation might occur, but it's often more common with the optic disorders, optic nerve disorders, and ampular disturbance and the OCT often localizes the problems quickly. So think macula first. If it's a blurred vision, central blurred vision, think always macula first. So what are the urgent red flag signs? Sudden onset distortion or central drop in vision, associated flashes, floaters, pain on the eye movement, RAPD suggesting the optic nerve disease or the retrobulbar neuritis, subretinal blood exudation or serous elevation of the macula. Then it has to be sent to the retina surgeon the same day and the urgent workup is needed in these kind of symptoms. Now, when the patient usually says the center is blurred, the lines look bent, I can see around it but not through it. So definitely this indicates that it's a macular disease. So focused history is very, very important. Onset, one eye or both eye. Unilateral is common in acute macular disease. Bilateral in symmetric complaints raise the either it could be a toxicity inherited or refractive issues. Distortion or blur is very important. Bent lines, micropsia, central missing patch, that is more commonly the macular. A dim or a washed out kind of image, usually it is due to optic nerve. Pain, photopsia, floaters, new flashes, urgent signs, they are all of the retinal detachment or a tear. Systemic and the drug clues, whether the patient's having diabetes, hypertension, pregnancy, steroid exposure, HCQs, previous injections and surgery, and OCT. A prior diagnosis often reframes the visit as recurrence versus progression. So if a patient reports straight lines are wavy, then move OCT earlier in your workup and assume the macular pathology unless proven otherwise. So coming to the examination sequence, acuity and the pinhole, I don't need to explain more about it. Pupil, color, red, resaturation, amsler, slit lamp plus media check, dilated fundus, examination, looking for drusen, hemorrhage, exudate, edema, ERM, hole or detachment. And most commonly is to get an OCT done. So if OCTs are unavailable in a single ophthalmology clinic where they sometimes not have an OCT machine, then drusen and pigment usually are the AMD spectrum, macular hemorrhage or the fluid neovascular process until proven otherwise. Cellophane reflex usually are either due to the epiretinal membranes or the round foveal defect with cuff is usually the macular hole. So best single next test in general clinic with central symptoms is macular OCT. So what adds in seconds? Usually use the OCT to separate drusens, edema, fluid, traction. Second, the MAC tail. You can see the ILM drapes line in the right remote corner down. You can see the vitreomacular traction, whether it's a focal or the broad or the macular hole or the CNVM. So multiple diagnoses can be made with the OCT itself. Now, coming to the pattern-based differential diagnosis, common macular diseases are wet and dry AMD. So older patients, drusens, metamorphopsia, central blurring, hemorrhage, they usually suggest it's AMD or the MNV. diabetic vein occlusion known as vascular risk, epiretinal membrane distortion out of proportion to the visual acuity loss, then OCT is definitely decisive. And CSCR, young, middle-aged, stress, steroid history, micropsia, serious decline. Think optic nerve, when pain with the eye movement, color loss is more than the acuity loss. RAPD or the disc edema or the pallor, and fundus sometimes nearly normal but vision is poor, then we have to consider as other neurological causes or the retrobulbar neuritis. Then do not miss or send urgently the neovascular AMD with blood or fluid, macula on retinal detachment, arthritic ischemic optic neuropathies, especially the jaw claudication, scalp tenderness, or the systemic symptoms. So, to remember it simply, treat, track, and transfer. So, in general practice, dry AMD, follow the AREDS2, clear cut, non center involving DME, optimizing systemic control, acute CSCR, usually observe for a month, not 3 months, but at least for a month at least. Monitor closely for stable ERMs, VMA without tractions. Retina referral is definitely required if there is a wet AMD, center involving diabetic macular edema, macular holes, and unexplained visual loss. So treat, track, and transfer. That is, refer to the retinal specialist. So a simple clinical algorithm to remember: central visual complaint, looking for the pain, RAPD, or any other major loss. Metamorphopsia, or is it a central scotoma? Looking for the 90D or the 78D examination, whether there is a blood, fluid, or there is edema. Then these are the things which requires urgent retinal referral. So measure monocular acuity first, pinhole, ask for specific about the waviness or the missing letters and reading difficulty. Do not let a quiet eye reassure you if the patient reports sudden distortion of vision. OCT is the highest yielding test for a suspected macular complaint as of now. And then take home messages: in a general ophthalmology clinic, decreased central vision is often solved by the disciplined history taking, rapid localization, and early OCT examination in these kind of cases. So the whole truth in the first case which I showed, the OCT was done in this case, and it turned out to be a pseudo hole. It was not a true macular hole. So this is how OCT helps you in diagnosing or distinguishing what are the different types of the macular abnormalities or the vitreomacular interface abnormalities which the patient has developed. So treat in this case, or whether to track and transfer, again, it depends upon what's the vision. If it's 6.6, we usually observe 6.6 to 6.9. Anything more than 6.12, then definitely it needs an intervention. Usually the pseudomacular holes usually do not turn up with very good prognosis. So the patient counseling is very, very important. And to the younger ophthalmologist here, whenever taking anything for surgery, you always, one thing we have to know, it is 90% counseling and 10% of the surgical efforts. So I just like to end it telling that vision is the art of seeing whatever is invisible to others. I would like to thank my colleague, Dr. Shailesh, who helped me in this. And thank you very much for the patient listening. I hope I have covered it in 8.5 minutes. Thank you very much.
Thank you, Dr. Srinivas. Dr. Ravi, you are also in somebody that deals with a lot of PG students, and where do you find most beginners have problem with initial diagnosis of macular problems? You're muted.
Ma'am, the problem I've seen in this younger generation is like most of them they try to do diagnosis macular lesions using an indirect ophthalmoscopy. So what I suggest is using a direct ophthalmoscope or a 90D or a 70D is must in every case, because so many times small lesions like a cysts or a hole we can miss an IDO. Okay, so IDO will give a gross view of the fundus, but to look at the finer details, 90D or 78D or a direct ophthalmoscopy is a must in every case. So in my practice, I always use a 90D in every case, and before disposing, so I will see a disc and macula at least.
Ravi Kulkarni sir, you are also a single practitioner. So how, I mean, you already have 24 years of practice. So probably, it's different compared to somebody that is beginning. But where in what areas do you find it becomes really challenging without an OCT? And for a beginner, what do you think is the best thing to do if a beginning practitioner, what do you think they should do if they don't have an OCT with them? And how have you been able to overcome this in your initial years?
Yes. Initially, that the basic things, Amsler grade, distorted vision, and Srinivas was telling, all those things, we have to spend little extra time with these patients. We cannot see just like any other headache patients or some visual acuity problem, something like that. Some macular problem, if you are suspecting, you have to spend extra time, if possible, diagnose it. Otherwise, you please refer to the center where they have a OCT. In the beginning of our career, we used to do like that. Once I have OCT, sometimes I don't get time to analyze all those things. It's a specialized work, I feel. I think better if you refer it to the specialized person and they will take care of it.
Yes, sir, I agree with you. Do we have any more points to add on to this?
I have one point. I
Yes,
just
sir.
want to recount an experience I had recently. This lady was an 80-year-old lady who came with blurring of vision in one eye. She went to the ophthalmologist, who is a very well-known ophthalmologist, who examined her, and he did the OCT also. OCT showed some fluid under the macula, and he promptly diagnosed it as an AMD and then referred it to a higher center. But by the time the patient, when the patient went to the higher center, it was found that patient actually had an inferior RD, which had spread to the macula. And on OCT, you are just seeing the fluid under the macula. And, you are thinking it's an AMD. So I think an indirect ophthalmoscopy, I agree with Ravi. Sometimes indirect ophthalmoscopy, you might miss macular pathology, but I would say in all patients, an indirect ophthalmoscopy of the entire retina is a must. And then you go and do 90-D lens examination so that you don't miss. And this is something that's been reported in the literature where patients with pseudophakia and inferior RD have been treated as CME for many months before the RD was actually found out. So I would say complete examination, then you go to the OCT. The problem is it's happening the other way around. We don't examine the patient, we jump to OCT. So I would put clinical examination as first with the indirect, with the 90-D, and then you do OCT. That will give you a complete information, will not allow you to miss anything like this.
Does anybody else have anything to add on?
Yeah, Dr. Soumya, recently, especially when patients are on ATT, we've seen very commonly that they do complain even after maybe a week or two. Sometimes I have had patients who complain of a little blurred vision, but we are always taught they'll have 6/6 vision, and we are always taught that the first sign or symptom that we have to look for is defective color vision. Very surprisingly, even their color vision is very normal. And when we subject them to a field, you will see that there's a nice central scotoma. And when you're doing a VEP, it shows a prolonged P100. So we'll have to not overlook their symptoms. Especially that's again very important. ATT patients, we should not rule out their symptoms just by a color vision. So that's another important thing I've seen with patients, especially on ATT.
Thank you, sir. Can we move on to the next talk?
Yes. Yes, I think you should.
We next have Dr. Purna Chandra. He has completed his post-graduation from Armed Force Medical College. And since I know him personally, I know that he carries that culture with him every day in his everyday routine. And he's always such a pleasure to talk with and interact with. He has also undergone additional training in inherited retinal disorders and electrophysiology. And he has completed preceptorship on ARMD from Sydney. He has many milestones, and he has achieved many awards, including the Rema Mohan Award for Best Paper, JM Bhava Best Award at VRSI, and Best of IG Award, amongst many other feathers to his hat. Welcome, Dr. Purna Chandra, and over to you for your talk.
Thank you so much, Soumya ma'am, and also the KOS, Dr. Shivarogi sir, and for the opportunity. So I just share my screen. So the topic given to me is, the macular OCT basics, which every clinician is supposed to know. I've just tried to cover, some of the basic aspects, followed by a few case examples. So hope my PPT is seen in full screen mode.
It's
Yes.
visible.
Yes, visible.
Thank you so much. Okay. So there are no financial disclosure. So fine. So why do we need OCT? For preoperative macular assessment? Because there are patients who are going for myopia, and also we need to document. And in case if the patient has any associated systemic disorders, knowing the other eye status definitely helps. If the grade of cataract is higher, or there are any other pathologies which are not letting you examine the retina in detail. And also to look for very subtle macular pathologies, which I'll show in some of the case example in denser cataracts. And also to look for any undiagnosed macular pathologies. As we know, like there are many disorders of the macula which cannot be picked up on clinical examination. So for which we need optical coherence. So these are the various imaging modalities presently used across different specialties in medicine. So our resolution of OCT ranges from 10 microns to 1 micron. So basically this OCT gives highest resolution compared to any other imaging modality presently available. So if you want to examine any tissue, the gold standard will always be the histology. So which is not possible in retinal practice. So in OCT is definitely it's analogous to the ultrasound. So if you plot a graph of resolution versus penetration, if you look at the ultrasound, it has a greater depth of penetration, but the resolution is definitely less. If you look at the confocal microscopy, it has got the highest resolution, and OCT falls somewhere in. So and this is the evolution of OCT. First time when it was introduced in 1996, the number of case scans which were done was very less, because of which resolution was very less. And everybody claimed we can see this in 90D also. What's the use of OCT? The real change happened in 2006, which changed the way we practice. In fact, not only the retina, the ophthalmology. That is the introduction of spectral domain OCT. So basically, if you see along the y-axis, higher the number of case scans, better is the resolution. Now we also have swept source OCT. So whenever you want to interpret an OCT, we should look whether the OCT has good signal strength. If the signal strength is good, definitely we can look into all the aspects. If the signal strength is not good, the subtle things can be missed, not gross things the way I'm showing in the screen. So whenever you get an OCT, how to read the OCT? No? So it's not like, just look at the OCT and saying there's a ERM, macular hole, or macular edema. We always need to follow the order. We need to practice this order for initial few months. After that, we'll be doing it in a subconscious level. So when you look at an OCT, first look at the pre-retinal space. If there's anything, it could be some hyperreflective or hyper, whatever it could be. Then look at the surface of the retinal surface. Are there any membranes, like retinal membranes? Then look at the contour. Contour should be normal. Then look inside the retina. Are there any intraretinal changes? Then go to the subretinal space, and also sometimes the choroidal changes also may be visible on the OCT. So these are the different layers and their latest terminology. Only thing what I want to highlight is the ISO extension, what we used to refer traditionally, has been changed long back. We don't no longer call it as ISO extension. It is called ellipsoid zone. So when you look at the OCT, you should pay special attention to this outer four hyperreflective bands. So this corresponds to external limiting membrane, ellipsoid zone, interdigitation zone, and retinal pigment epithelium. So all these layers should be intact so that it gives the outer retinal integrity is good, in which case the visual prognosis is also good. The external limiting membrane and interdigitation zone may not always be seen or picked. So whereas ellipsoid zone and RP will always be seen, if these two lines, if there is any disruption or missing, then definitely there is something wrong. Fine. So let's go through some of the case example. This was a 56-year-old female, known case of diabetes. She had a NS2 grade of cataract along with post-stage of capsular cataract, and left eye had NS1. That and the corresponding vision was 6/18 in 6 and 6/12 in 8. So if you look at a fundus examination, in the right eye, there are very subtle, RP changes around the fovea and also in parafoveal region. Left eye was apparently normal. So under periphery, as Muralidhar sir and Ravi was rightly mentioned, we should never forget to examine the periphery in these patients, because in this age group they are more prone to develop many peripheral retinal disorder. So luckily in this lady, the periphery was also normal. If you look at the OCT, the vitreoretinal interface is normal, the contour is normal. Intraretinally, there are more small cystoid changes. These are called atrophic cavitations, what we call. So this is seen in some disorder called parafoveal telangiectasia, and these cases don't need any referrals. You can go ahead and plan cataract surgery in case you see these kind of subtle changes. At least they don't need an immediate referral. Okay, so you can just counsel the patient regarding what is there. And usually they, unless they develop secondary complications, the prognosis is relatively better compared to other macular diseases. Right. So coming to the second case, this was a story of 76-year-old male who presented with blurred vision, known case of diabetes. He had already undergone cataract surgery in the right eye. But if you look at the vision, the outcome was not that satisfactory. It was 6/12 N8. So now he has come for the left eye surgery, and this is the grade of cataract and the corresponding vision. So if you look at the right eye fundus, so clinically you can clearly make out there is an epiretinal membrane, the possible reason for less vision in the right eye. And the left eye, it clinically appeared normal. Just have a look at the left eye OCT. So though it's appearing clinically normal, if you look at the OCT, the hyaloid which is attached to the fovea, and also it is playing a traction on the central part of the fovea, what we call it as vitreomacular traction. Okay. So these kind of VMT in early stage, the fundus can look very normal clinically. So we have to, unless there is an OCT, it's pretty difficult to put these kind of changes, because post cataract surgery or any intervention, they will have a very disturbing metamorphosia. And if you do any intervention in the eye, the VMT is likely to worsen, and it may resolve spontaneously, or it may follow the other track and may develop into severe grades of vitreomacular traction and also a macular hole. So when you see such changes, first thing is you just counsel the patient, give them arm's length rate monitoring, and repeat OCT after 3 months, because most of the time it may resolve spontaneously. If it is progressing, it definitely needs urgent referral to a vitreoretinal surgeon. Fine. So the third case is a 72-year-old male, no systemic illness. They had a NS2 grade of with PSC in right eye and an NS1 in the left eye. The corresponding vision of 6/24 and 6/80. And this fundus in the right eye, the foveal reflex looked dull. Left eye was quite okay, and peripheral examination was quite unremarkable. So if you look at the OCT, the both eye OCT grossly looks very much normal. There's a normal contour, everything looks fine. But in the right eye, if you carefully look, in the subfoveal region, there is a disruption in the ellipsoid zone. So this is a classic case of, photic retinopathy. So which usually happens due to, direct sun gazing, or if there is an exposure to laser or welding arc or very high intensity light, this can happen. And these can be seen in some of the patients I have seen, those who practice this habit of, gazing into the sun. So in those patients, it may be present bilaterally, and most of the time the history will be missed. Recently, I had a case with an pediatrician. Preoperatively, this very subtle change, her changes was even more subtle than what I'm showing now. So she had undergone cataract surgery, and she was she was very unhappy post surgery because she couldn't read, because their near vision will be markedly decreased. That means they may make them force and read N18, but they'll not be comfortable. So that is very important, because clinical also looks normal. OCT also, if you're not careful, you're likely to miss mistakes. Another case is 71-year-old female, known case of diabetes, had undergone cataract surgery in the right eye with a reasonably good vision of 6/9 and N6. Now had come for the left eye cataract surgery. So now if you look at the OCT carefully, the right, I was talking about the signal strength. Compare the right and left eye. The left eye signal strength is very poor because of the higher grade of cataract. And if you look at the right eye, it does give a clue that ellipsoid zone is not very continuous. It is disrupted. So that means she has an age-related macular degeneration. And left eye also, though the signal strength is poor, the ellipsoid zone, we can make out it's not very prominent, and also there is a very subtle amount of RP changes. In these kind of cases, you have to be very careful in counseling, and better to avoid this multifocal kind of lenses. You'll never be happy with that. Better to go for a monofocal lenses, and counseling is very important. so that they need to have a very realistic expectation post-surgery. And also you need to tell about the progression of the disease, because if this AMD increases after 4 years, they should not blame your IOL. Okay, so that's very important. So I'll just finish with a couple of more cases. This was one more case, 73-year-old male, known case of diabetes mellitus, with a vision of 6/9 and 6 in the right eye, post cataract surgery. Left eye now he has a NS2 plus PSC cataract with 6 by 36 vision. So if you look at the fundus photograph, right eye macula has very few hard exudates in the parafoveal region, whereas left eye has more hard exudates compared to the right eye. And peripheral examination was quite unremarkable. So if you look at the OCT in the left eye, there are some cystoid changes. I mean, this is the eye which is being planned for the cataract. What do you do if you pick up these cystoid changes? So there are two options. First, we can treat the macular edema, wait for the macular edema to resolve. So otherwise, the second option could be you can combine both. You can, do cataract surgery. Along with that, you can inject either anti-VEGF or a steroid. Anti-VEGFs are usually preferable. So that can be done. So either way, but you need to counsel the patient. Otherwise, if you don't address this edema, this is likely to worsen with cataract surgery. And we've seen that consistently happening. And biomarkers are also in favor of that. Perfect. So, and also these cases, they need a little longer NSAIDs compared to any other cases post-operative. So one more case of diabetes mellitus along with the chronic kidney disease. So right eye had a very diffuse PSC, vision was 6/75. Left eye grade of cataract was less, but the vision was more or less compared to the right eye. Again, if you look at the fundus, he had an history of undergoing vitrectomy in the right eye. You can see the clear cut oil reflex. This is status post vitrectomy with oil filled eye. So left eye, there are multiple membranes in the preretinal area. And this is his periphery. If you look at the OCT right eye, it's decent enough. So outer retina is not very healthy, quite okay. So it's likely to improve with right eye cataract removal. If you look at the left eye, so the membranes which I showed in the color fundus photograph, they are applying a significant traction on the macula, leading to macular edema and also a neurosensory detachment. So these requires an urgent reflective VR surgeon. It's preferably, better to plan the combined surgery, that is both cataract and vitrectomy together. So otherwise, if the patient can understand and counsel, we can remove the cataract and the vitrectomy can be planned in the next couple of weeks. Fine. So this was an 83-year-old male. He came with history of metamorphosis. Had already undergone, cataract surgery in the left eye. Was due for a cataract in the right eye. He had an anti-subcapsular cataract in addition to nuclear sclerosis. So this was his right eye, very subtle ERM, and the left eye macula clinically appeared normal. So now periphery was also quite unremarkable. So now if you look at the OCT of the right eye, there are multiple membranes in the preretinal space. So though those membranes looks very, multiple membranes and all, if you look at the macular architecture, it's not that distorted. Okay, so there are focal points of attachment and all. It's not disturbing the macula in that way. So in these cases, it's a dicey. You can go for vitrectomy, but if someone does just the cataract and follows it, that is also fine. Okay. Right. So, and Soumya madam, do I have a couple of more minutes to finish 2-3 cases?
You can take
Maybe.
another minute. Yes, you can take one more minute.
So this was, I'll just quickly rush through because I just lost. So right eye had a vision of 6/24, left eye had an early PSC, but right eye vision was, disproportionately less compared to the grade of cataract. And he was also on multiple anti-glaucoma medication, especially the prostaglandins. If you can see the right eye, the foveal reflex appeared, left eye macula apparently appeared normal. Periphery in the left eye had an old Barras-Desa scars. But if you look at the macula, there is a very early macular edema. And these cases, since they are also on prostaglandins, they are more prone to develop, post-surgery CME. Need to tackle that and also counsel the patient and keep them informed about this. So this was again 83-year-old male hypertensive for cataract surgery. Again, if you look at the grade of cataract and vision, it's not correlating. So just look at the fundus photo. The right eye, there is a predominant scarring and atrophy along with some hemorrhages, which indicates both scarred and an active CNVM. Left eye, there is a very large macular scar with an area of atrophy. And this is the corresponding OCT changes. So left eye, if you see, the fovea is completely atrophied. The prognosis is very extremely guarded. But at the same time, we should tell one thing to this patient that just tell them they are not going to go blind. Okay. So irrespective of whatever the severity this macular degeneration might progress, they will always retain an ambulatory vision. So the last but one case, again, so 44-year-old male with a cataract. The first thing is whenever an young patient comes with a cataract, especially the PSC, should always suspect there is something wrong. So that is what in this patient, if you look at it, there's some degenerative changes in the macula and also in the mid periphery with bone speckle-like pigmentation. So this is a case of not bone dystrophy, which is a form of an early RP, that is retinitis pigmentosa. So if you look at the OCT as compared to the normal, the outer retina is completely degenerated. Again, the prognosis is extremely bad, and we should not jump and operate those PSC cases because that may not, the results may not be that great. Right. So the last case is a 65-year-old female, known systemic illness, vision of 6/18 in both eye, and corresponding rates of cataract are shown here. So if you look at the fundus, it was apparently normal. So with the left eye, she had this yellowish lesion, which we call it as myelinated nerve fibers. So otherwise, everything is normal. My MNF, that has got no importance. You can just follow it up. That does not require any intervention. But if you look at the OCT, there is subfoveal fluid with an vitaliform-like deposit. What we call it as adult onset vitaliform deposit disease. These again don't require any intervention. You can just follow it up. Just avoid doing, multifocal IOLs or any premium IOLs, or these can be followed. To conclude, I would like to say macular OCT is a powerful extension for clinical examination when interpreted systematically along with the clinical correlation, because OCT should never be taken in isolation. It should always be correlated with other findings. So then it simplifies diagnosis, guides management, and also definitely improves patient care. Thank you so much.
Thank you, Dr. Purna. I think those were some fantastic cases that you were able to put together. Muralidhar sir, do you have anything to add on?
No, I think today he has covered it very beautifully. Thanks, Purna, for very interesting cases. Because clinically, the problem is OCT has become extension of our eye, actually. It can pick up lesions that our eye cannot see, and it becomes especially important in the context of hazy media with cataract. And today we have very demanding patients who come to you for cataract surgery. They want the best vision, and you are also looking at giving them the best vision by doing all kinds of things like a toric lens, multifocal lens, EDOF lens, and all that. So in this context, it becomes very important to know that patient has a normal, healthy macula. And clinical examination is not enough today to really come to this conclusion. We need to have OCT in order to, pick up these lesions like what Purna very typically showed. And I think it has become a standard part, but I don't know. I know it is a standard practice in cities. I really don't have any idea how much the OCT penetration is in the tier 2 and the smaller places. I don't really have an idea. Maybe as KOS office bearers can take up just a poll and see what is the degree of availability of OCT in the other centers outside the big cities, outside the major cities and tier 2 cities, the smaller places, how many places. But on the other hand, we also should understand that in the peripheral place, the type of cases they get may be not so demanding. There may be patients who are giving 6/18, 6/24, 6/60 vision, who need cataract surgery, and they're happy with, good vision, whatever vision they get. So it all depends on the population you're serving, depends on that also. So, but today OCT has come to stay, and it is going to be an important part of your pre-op workup in most major centers.
I agree with you, sir. So I practice in Coorg, and I know that most of us have OCTs in our practice here. And like you said, not only that patients are demanding, but we also want to give the best outcome. It's also a responsibility from our side that we don't miss out on something. And I think more than where they are staying, it is their lifestyle today. So people, like you said, people who are very active, who are driving, they want to have really good vision. and people who are more sedentary, they may be able to accept something less than perfect. Although more or less people, because of the internet, everybody knows everything. So I think there is like a sort of an equality amongst the demands of the patient. So everywhere, I think we need to be careful and be able to deliver that. Dr. Ravi Kulkarni sir, what do you say? How is it in your place? Because both of us are not in a big tier 1 city, so I think
Yeah, we are in periphery, but I have OCT, and nowadays we have made it compulsory for all the patients, irrespective of their socioeconomic status, whatever it is just a routine scanning. And I have IOL Master 700. It gives a macular 1 millimeter gross idea. If there is some change, then I'll shift them to the OCT and see that. Most of the patients I do. Whenever there is the mature cataracts, we can't do. Otherwise, we do it. And the OCT is available in almost all cities. Haveri it is available. Radebendur it is available.
tier 3 cities, yes. And would you say your patients are as demanding or less demanding than, let's say,
That honestly, I don't consider. Every patient should get good vision. If somebody is demanding and honestly speaking, if they are too much worried about their vision and all, I honestly refer them to the ear centers because they eat our head a lot.
That's why Dr.
Patients,
Muralidhar
because
has to address all of them.
one thing we need to understand, I think, for instance, who are planning to invest and all, there are many models which are coming up with an OCT plus A scan combined. So that's a better option because now OCT may not be available everywhere. The internet and phone is available even in villages. So even they have access to information, they know things and
Yeah.
all. Especially if you're planning for a premium, I mean that era is gone, not demanding demand. Once the patient is not demanding, children will be demanding. They know.
Correct,
So
correct.
any premium procedure, even if you don't have, better to get an OCT because it reduces your stress level. At least you are sure what is there. You have consulted it.
And
all
if
that.
if a referral center is available somewhere, I think no harm in referring the patient at least for an OCT and getting them back if there is a doubt or if there is a gray area somewhere.
Like, so much of demanding patient, even if they don't think about their mind.
Yeah. Thank
I have
you.
a point to make. Just
Please.
like people order OCT, but they forget to see where is the lesion. So it's just ordering a OCT and seeing one image is not going to serve. We have to scan the entire macula as much as possible, because suppose there's a macular hole, if you do OCT in the edge, you may get a normal OCT. So it's very important. The person who is ordering the OCT has to see the entire the macular cube before commenting on the report.
This is a very important point, extremely important point what Ravi made, because you have seen some of them, referring for OCT and they just ask for the printout. Please don't go by the printout if the patient brings. Okay, the cross section, what you're looking, maybe normal pathology could be there in the other OCT. Always speak to the person whom you have referred to send the complete cube and speak to them your phone, is it okay and all that. Just don't rely on the printout what the patient
If
comes.
possible, you can get a video of the entire OCT.
That is one of the reason, when we want to repeat the OCT, even if they have done OCT in the other centers, insist on repeating it. If they ask, why recently done, tell them that cross section can be normal, pathology could be in the other thing. So even if it is done 1 week back, so preferably, should repeat it on your own and analyze it in the machine.
Thank you. We'll next move on to our next talk by Dr. Pradeep Sagar. He will be speaking on vitreomacular interface disorder. Dr. Pradeep is a consultant VR surgeon at Shankar Eye Hospital, Shivamogga, and he is also on the advisory board for Springer Nature Ophthalmology and Therapy. He has served as deputy editor for VRSI, and he has plenty of publications in peer-reviewed journals, and he's also very active academically. He has won the IGA Gold Award, IGA Honored Award, and the Dr. A.S. Guruprasad Award for Best Medical Retina Paper, amongst others. Welcome, Dr. Pradeep. I've heard so many good things about you, and I'm really looking forward to your talk today.
Thank you, ma'am, for the introduction. Are my slides visible?
Yes, Pradeep.
Yes, thank you.
Good evening, one and all. At the outset, I would like to thank KOS for giving me this opportunity. I will be discussing about the vitreomacular interface disorders. In this presentation, we will be learning the natural history of vitreomacular interface disorders, the indications for observation, surgery, the gray area in the management of these cases, and some practical tips. So we need to understand that the PVD is a physiological process, the posterior vitreous detachment. So with time, like when the patient ages, over the macula, we see that there is a separation of posterior cortical vitreous from the retina in the perifoveal area. The fovea has a strong vitreoretinal attachment compared to the rest of the macula. So this particular entity wherein the foveal contour is maintained is termed as vitreomacular adhesion. So what happens to vitreomacular adhesion is that it can mostly resolve in most of the cases when the vitreous detaches over the macula without causing any disturbance to the underlying fovea. So, and the posterior vitreous detachment can proceed to incomplete PVD and a complete PVD. The other possibility is that the vitreomacular adhesion can progress to a vitreomacular traction. So in eyes with abnormal vitreofoveal attachment, as the vitreous tries to separate from the underlying fovea, it would exert traction on the fovea, and there may be subtle disturbance in the contour. This can be asymptomatic, but when the traction worsens further, there can be distortion of the foveal architecture with development of cystoid spaces, which we term as vitreomacular traction, and this can be asymptomatic or can be associated with the blurred vision or can induce metamorphopsia. So a VMA can either resolve or progress to a VMT. What would happen to the VMT? A VMT can resolve on itself if the vitreous separates from the underlying macula without causing loss of inner retinal structure or without deroofing the cystoid spaces. So in such cases, the cystoid spaces regress and eventually they may attain a near normal foveal contour, and this is documented in up to around 35% of cases. The VMT can also end up in a lamellar hole. So if the traction worsens and if there is a thinning of inner wall of cystoid spaces, when the vitreous tries to separate from the fovea, it can cause deroofing of these cystoid spaces and loss of inner retinal layers. So this ends up in a lamellar hole, and this is a possibility in close to around 10% of cases. It can be again asymptomatic or can be associated with the metamorphopsia or blurred vision based on the extent of damage. So the VMT can also progress to an occult macular hole. As we can see in this case, the cystoid spaces may coalesce together to form a large cyst, which is a stage 1A macular hole. The persistent tangential traction can result in an outer layer defect, which is termed as a stage 1B macular hole, which is an occult macular hole. So a VMT can either resolve or can end up in a lamellar hole, or it can progress to an occult macular hole. So an occult macular hole can resolve on itself. So this is a stage 1B macular hole, but if the posterior cortical vitreous separates without deroofing of the outer occult macular hole, we see that it can resolve and can end up in a normal foveal contour, but with some disturbance in the outer retina. So the textbooks mention around 50% of cases can end up in this, but there is no enough academic, the evidence from the literature as such. So occult macular hole can also progress to a full thickness macular hole. As we can see over here, the stage 1B can progress to stage 2 when the posterior vitreous detachment does occur and there is a attachment just at the edge of the fovea, edge of macular hole, which is a stage 2. So an occult macular hole can resolve or it can progress to a stage 2 macular hole. The stage 2 macular hole can also resolve on itself if there is a separation of the vitreous from the edges of the hole. Due to the relief of the AP traction, the hole can close, but this is a very less likely possibility. Just around 15% of cases may end up in this. The rest of the cases will progress to a stage 3 or a stage 4 macular hole. The stage 3 is one in which the vitreous separates completely from the edges of the hole, and stage 4 is one there is a complete PVD when it's detached even from the optic disc. So a stage 2 macular hole can either resolve but in a less number of cases, or it can progress to a stage 3 and then to a stage 4 hole. So coming to the ERM is due to vitreoskisis. So it occurs in eyes with abnormal vitreoretinal attachment. When the vitreous tries to separate, there may be splitting up of posterior cortical vitreous and the lembrant vitreous may remain on the surface of the macula. So the metaplasia of these remnant hyalocytes can result in formation of a contractile membrane, which is the epiretinal membrane. A centripetal contraction of a foveal sparing epiretinal membrane results in a pseudo hole, which can be asymptomatic or can be associated with metamorphopsia or blurred vision. A centripetal contraction of a foveal ERM would result in loss of foveal contour, and the further contraction could result in further distortion of the fovea. So the ERM can coexist with a VMT or a macular hole because all are related to a strong vitreoretinal attachment or an abnormal vitreomacular attachment. So when do we observe these cases? In cases with vitreomacular traction, in eyes with fairly maintained foveal contour, for example, in this case, we can see that there is just a minimal tenting as Sir was showing in one of the cases. So if the patient has a good vision, doesn't have any symptoms, we can definitely observe such cases. Whereas this is a case in which we see that there's a definite disturbance, but she was completely fine. She was like, I can read very well. I don't have any such issues. So we decided to just observe, but we made sure to observe that, we made sure that she has a periodic review every 2 to 3 months and was advised to monitor herself with Amsler's grid at home. The reason for observation is that there's a chance that 35% of cases can resolve on itself. In cases with epiretinal membrane, eyes with fairly maintained foveal contour, as we can see over here, or in the right side, we can see that there's an ERM which is just away from the macula without distortion. These cases can be safely observed. This is a case in which we see that there's a significant distortion on the macula on the color photograph and there is a pseudo hole, but she was asymptomatic and she was not really keen on any intervention, so we decided to observe. But again, there is a possibility that this can worsen and they can end up in symptoms. So they also need a periodic follow-up. So what are the indications for surgery? A symptomatic vitreomacular traction is a definite indication for surgery. As in this case, we can see that the presenting vision was less and there was a significant traction. And this is the post-op at 1 month. We can see that there's a near normal foveal contour. So if there's a documented progression with onset of visual symptom, again, it's an indication. For example, the same case which I mentioned earlier, at 2 months, the vision came down. She told that she is not able to read now because the other eye was even bad. So in this case, we considered surgery at this point, and this is the post-op at 1 month. With ERM, again, the same thing. Symptomatic ones with blurred vision need surgery. As we can see here, there is a combination of VMT and ERM with significant distortion. But here we can see that even after surgery, the ectopic inner layers persist. That is, the fovea should not contain the inner layers. But here we can see that the inner layers are present even at the fovea. So these are the cases which may not have a very good quality of vision. So it's not better to wait till this stage, but if it's progressing, definitely we should take up slightly early. But if they are presenting late, there is no other option. The other option would be like a patient with almost a good vision, but metamorphopsia. He was a 70-year-old gentleman. He came with metamorphopsia. I asked him that it's okay, it's not that bad, he can observe. But within 15 days, he came back and told that it is very disturbing and we went ahead with surgery and this is the post-op. So a documented progression with visual symptoms is again an indication for surgery. As we can see, this is a case at presentation. This is at 4 months and this is at 15 months where we can see a pseudo hole. So we considered surgery and this is the post-op. So in macular hole, the stage 1B, if they are symptomatic, we can consider surgery. As I was mentioning, there is no literature backup to say that 50% resolve, but the good number of cases will definitely resolve. But in this patient, the patient was symptomatic and wanted to undergo surgery. This is post PPV and ILMP. This is post 2 months. And this is at 10 months. We can see that there's a near normal foveal contour with restoration of the ellipsoid zone. The stage through 2, 3, 4 holes, most of the VR surgeons would suggest surgery, though we know that the resolution of stage 2 hole is possible. This is a minority of cases. So usually we consider surgery in these kind of cases. A lamellar hole associated with an ERM is definitely an indication for surgery, as it's usually associated with symptoms and it can even worsen and even enlarge the lamellar hole. So there are a lot of cases which falls in the gray zone. As we can see over here, there is an epiretinal membrane, but the cataract is significant. The patient doesn't have metamorphopsia, but the vision is low, which may be due to cataract. So we are not able to explain the visual symptoms whether it's completely due to cataract or the ERM is contributing. In such scenarios, like one option is to undergo cataract surgery to reassess. If the symptom persists, then process and proceed with vitrectomy. If it's asymptomatic, then just observe. Or the other option is to go with a combined surgery. But this is again like individual surgeon preference. So know your VR surgeon, what they would prefer, discuss with them and then take a call. In eyes with vitreomacular traction or ERM with significant loss of outer layers, as sir was showing that there is no ellipsoid zone or no external limiting membrane, these are the cases which may not do well. So even if you do surgery, they may not improve much. But again, we are not very sure, because few may consider surgery with the hope of some improvement. So asymptomatic stage 1B holes, again, like it's a gray zone. Some may consider surgery, some may not. Macular hole with a flat edges, wherein the chances of visual improvement is less likely, again is a gray zone. Some may consider surgery, some might not. And it also depends on what the patient is expecting. And old macular hole, this is a case in which we advised surgery 8 years ago, 7 years ago. This was a stage 2 macular hole where the posterior cortical vitreous was still attached to a edge. But at 7 years, the patient came, and this is the situation. Definitely, at this point, we may not be really considering a surgery. A lamellar hole with the absence of an ERM, like here we can see that there is an epiretinal proliferation, which is usually non-contractile. It is not a contractile structure. But even some surgeons would consider surgery, some may not. So this is a gray zone. So the practical tips would be that we should consider OCT in suspicious cases, particularly the vitreomacular interface disorders and VMT may be easily missed in hazy media. So it's better to do OCT in suspicious cases prior to planning cataract surgery. Peripheral screening is a must in these cases, because vitreomacular interface disorders are due to abnormal vitreoretinal attachment. So the peripheral abnormal vitreoretinal attachment can predispose to retinal break. Just to recall, this is one of the case which I discussed earlier. He had a supratemporal HST with a subclinical retinal detachment. So ensure that the VR surgeon you refer concur with your decision. It should not happen that, like when you refer, they should not say that probably this should have been operated earlier. So it's always better to know your VR surgeon, what they expect, and always be in the same page. So the other option is, it's always better to give options to the patient and let them decide what they would prefer. As we are already discussing, like some patients may be happy with whatever vision they have. So in that scenarios, it's not that great to even push for a surgery, because post-surgery, if the vision is the same, they may feel that it's not something that was worth. So to summarize, asymptomatic VMTs and ERM can be safely observed, but ensure a regular follow-up. Symptomatic VMT and ERM and cases with documented progression require surgery. The surgery would be beneficial in most of the cases of macular holes. Both the primary ophthalmologist and the VR surgeon should be on the same page. Thank you.
Thank you, Dr. Pradeep. That was a really good presentation. Out of curiosity, your 70-year-old patient who had metamorphopsia, how did he do post? To what extent was the metamorphopsia relieved?
Like he didn't come for, like he has come only for 1 month follow-up. At that time he was fine. After that he didn't follow up, but at that time he was mentioning that it was almost the same. Like we need to see for a longer follow-up. Without that, it's difficult to say, because it's not these are the symptoms. VMTs usually resolve fast, but ERM, sometimes they may not even restore to a normal contour, and the symptoms would slowly reduce over time. Sometimes it may take even 3 to 4 months.
Yeah. Muralidhar sir, in your experience, how much time does it generally take, and does it completely resolve when it comes to metamorphopsia in these patients?
Mean post-operatively you're talking about?
Post-operative.
Post-operatively, we all know that even though we do a wonderful surgery, ERM surgery is one of the most easiest surgeries among all retinal surgeries, but unfortunately the results don't always, come meet the expectations of the patient and the doctor as well. So most of the patients, the metamorphopsia, it all depends on the degree of vision. If the vision is, let's say, 660 or 636, 624, it doesn't improve so much. It may 1 or 2 lines, and patients are always left with some distortion. If the initial vision is, let's say, 618, 612, and then you do surgery, I always tell the patient that the look distortion will reduce but may not disappear completely. So we always prepare the patient for some residual visual deficit. We never promise that, yes, we're going to make you completely have normal vision. That is something we all do as retinal surgeons. But as you say, even in the OCT, it takes a long time for the foveal architecture to come back to normal. Many of them don't regain the foveal contour at all, even after many months and years. So we should prepare the patient for, accepting that the vision is not going to improve to normal. That's the basic thing that we have to do in all these vitreoretinal interface disorders.
So, what is your threshold for advising surgery? As in, I was a bit surprised as a cataract surgeon to see Dr. Pradeep take up somebody that was 6'6", because in my understanding, I would have thought that retinal surgeons like to wait longer, but obviously I stand corrected. So do you have a certain threshold for taking the patient up, or is 6'6" still okay to take up for something? Would you like to operate them earlier, and do they have better outcomes if they're taken up earlier?
Fortunately, we don't face such situations where patient with 6'6", and then we have to really break our head, should I operate on this patient? Because most of the time we face other situation. We see an ERM patient, vision is 6'9", and because the other eye is good, patient is totally asymptomatic. That's the situation which what we face. Now, to answer your question, what is the vision? I don't have a cutoff vision. I don't say that I won't operate on a 6'6" patient. Because patient has 6'6", I would operate depending on the symptom of the patient. The symptom is really strong and the patient is bothered, and if I'm convinced that, yes, this is the cause for the distorted vision, I don't mind operating if the vision is 6/6. It's the symptom and the correlation of the symptom with what you find. If it's strongly correlated, I would operate even with 6'9" vision. Yes, I would. But having said that, the number of cases that we do with good vision are not that much.
I think I'm introduced to a new generation of refractive retinal surgeons. We thought we were only refractive cataract surgeons, but so much to learn.
Ma'am,
Yes.
it's a very completely gray zone, as Ravi was rightly mentioning. I mean, I don't think it can be taken as a general sentence and all. Multiple factors needs to be considered. Even post-surgery, we don't know whether the metamorphosis is improving because of the returning of the contour, or patient is neuroadapting it. Because we don't, without surgery also, over time, that's the same thing. It's a gray zone. I don't think we can have a clear cut, I think,
Yeah.
which
Yeah.
Pradeep was also repeatedly mentioning it. We have
Yes.
not reached
But
the
do we
stage of
generally-
retina refractive. Yes, ma'am.
Yeah, I know. I
Yes,
was
ma'am.
just joking when I said refractive retinal
Yeah, I
surgeons.
know.
Yeah.
I was-
But do we generally see patients neuroadapting to metamorphopsia? Again, this is not something that I'm familiar with, so I want
not,
your...
not only metamorphopsia, even for the lesser vision, I have seen patients with ARMD whose one eye is 3/60, other eye is 6/12. They're very unhappy. When the other eye becomes 3/60, eventually they do well. So that is being seen. See, the metamorphopsia again, I feel is personality driven. The people who always, close one eye, repeatedly check that, they will never. People who ignore and they always use the binocular vision, they are likely to adapt little faster. So like that. So that is something which I always tell my patient, never close the other eye. So that, but some patients, they close. I mean, people who, the fact that they are present to it, they're repeatedly checking it, 6/6. So because as Muralidhar sir was mentioning, if the other eye is 6/6, they should not ideally manifest unless it's a bad.
I have a comment too. So usually these patients with ERM and all, usually they will have a very good vision. So I always avoid surgery as much as possible and try to follow up. If there is any documented progression or worsening of the vision, then that is the time even patient also is convinced. And because as a beginner in a vitreoretinal surgery journey, it's better to avoid such cases, because especially in an anomalous PVD, when there is an abnormal or an very adherent vitreous, it's very difficult to induce the PVD, and we tend to get breaks in the periphery. So these cases are not like a cakewalk for a beginner surgeons. So it's definitely be careful in operating such cases.
Yeah, one point, if I may add, Dr. Soumya. Yeah. One of the other gray zones or late referrals are especially patients with glaucoma. and with epiretinal membranes or any vitreomacular concerns. Here, what happens is the treating specialist always prioritizes glaucoma, but it's very important to remember that when the glaucoma is advanced, it's the central macula, the tunnel vision, which is depending on. So, one of the slides which Dr. Pradeep loved the animations which he was showing, that longer the ERM or the vitreomacular issue stands, the outer layers start to deteriorate, and operating then really doesn't restore good vision. So very important that if you have glaucoma, you should not be worried about a wipeout, or even in a moderate glaucoma, you should always address the vitreomacular interface, be it an ERM or a VMT or a macular hole. Very important, so that they have better quality of vision long term.
Can I make one point, ma'am? Like,
Yes,
to
yes,
clarify,
sure.
I think I totally agree with
No, that's yeah, we just picked
Purna
up
sir
on.
regarding operating on eyes with good vision.
Yeah.
Like, what I'm trying to tell is, like, it's not just the vision, even the symptoms we do consider. Yeah, definitely. I am a less aggressive surgeon. In fact, like, I ask them to wait if they don't have symptoms. But when, like, in this case, even I asked him to observe, but since the patient kept on coming back repeatedly with this is disturbing, so we considered surgery. But like earlier books, if we go through, they mentioned that 618 as a cutoff for ERMs, but that's what I was trying to convey, that it's not really so. Like, we do take care of, like, we really try to address the patient's symptoms and try to do it early, when the chance of recovery is even better than allowing them to go to even more advanced stages. That's what I was trying to convey.
Yes, no, of course, it's a very interesting case, even for us to understand as cataract surgeons, because we tend, like you said, if we were to go with the classic books, then we would probably want to wait till 618. But I think it's a good takeaway point that we don't need to. And it's always good to start this discussion early so that they're motivated. And maybe when they're noticing these changes worsening, then they can always take that decision whether they want to get operated. And then also now we understand that probably there's a little better chance of regaining normal architecture if it's done at the right time.
Thank you.
We'll move on to the next talk by Dr. Ravi. Dr. Ravi is also a very dynamic retinal surgeon, and he is associate professor at RIO BMC at Minto Eye Hospital. Welcome, Dr. Ravi, and over to you for your talk.
Good evening, everyone. At the outset, I would like to thank KOIs and Dr. Soumya ma'am for this opportunity. Can you?
I have stopped sharing. Yes.
Is my slides visible,
Yes.
ma'am?
Yes, it's visible.
Yeah. So I will be talking on the macular changes in myopia. So as we all know, there is the advent of these mobile and electronic gadgets, and also the reasons known or unknown. There is increase in the incidence of myopia, and all the more more and more incidence of patients.
Your screen is not visible, Ravi. I think your screen went.
You stop sharing and again reshare. No.
Can you see, sir?
No, not yet. No.
Sir, 1 second, sir. Can you see?
Yeah. Make it big, full screen.
Make it slideshow.
Yes, sir. Yes, sir.
Yes, now it's fine.
Sir? Yes, sir. So, coming to the definition of myopia, we all know that there is simple or developmental or school age myopia, where there is low to moderate myopia low is up to 2 diopters and moderate is 3 to 6 diopters. So usually this myopia progresses till the 2nd and 3rd decade, and it stops by 3rd decade. Then coming to the high myopia, where there is a refractive error of more than 6 diopters or an axial length of more than 26.5 diopters, millimeters of axial length. So pathological myopia is nothing but high myopia with associated pathological changes, that is in the posterior segment, that is the lacunar cracks or a chororetinal atrophy or a posterior staphyloma. The incidence of pathological myopia varies from 0.9 to 3% from country to country. Okay. So what is the pathogenesis of this high myopia or pathological myopia? It's one is the aging, genetics, and biomechanical factors, and also hypothesis that there is an anomaly in the immetropization, that is because of the retinal defocus or a lot of molecular signals which are released from the choroid and retina, which is causing an excessive elongation of the axial length, leading to a chororetinal stretching and a thinning, and also associated structural changes in the collagen. So, and also there is something called a Stiles-Crawford effect, that is because of the alteration in the arrangement of the photoreceptors in case of this high myopia because of the stretching of the sclera. So how does it matter? Why do we need to worry about these cases? Because these are the young patients and they are having like a very productive time in their this thing. So it affects their job and the family. So, and also they're bilateral, and once it affects, they're irreversible. So that's why we need to address these cases, and any visual symptoms we need to treat as early as possible. So what are the clinical features which we see in myopia? Right from the optic disc, there is a tilted disc and the crescent, temporal crescent, then there are foveal changes, then there are peripheral changes like in lattice degeneration, retinal or a tear. So what are the macular changes which we are talking about in myopia, right? It varies from tessellated fundus to a complete macular atrophy or a thinning of the macula. Coming to the classification of the pathological myopia, way back in 1975 by Curtin, which gave based on the fundus examination. So divided into 5 primary types based on the location of the staphyloma in the posterior pole, then a combined types based on the combinations. Then the main drawback with that Curtin's classification was they addressed about the staphyloma. They didn't tell about the atrophy. So what we are thinking, telling about the chororetinal atrophy. Then came the classification by Matsui et al. From Tokyo. So they graded from category 1 to category 4 based on the no macular lesions to a tessellated fundus to a diffuse choroidal atrophy, then a patchy and a total macular atrophy, along with signs like aqueous cracks, myopic neovascularization, and fugue spots. The earlier classification did not address the tractional component which we normally see in the OCT. Okay. So then came in its ATN classification, which is a recent classification, which graded the 3 components, that is an atrophic component, a tractional component, and a neovascular component. Coming to the few clinical features, what I mentioned. So this is a tessellated fundus. Because of the stretching of the sclera and the choroid, there is a loss of RP along with the atrophy of the capillaries in the choroid. So which causes the hypopigmentation and also the highlighting of the medium to large choroidal vessels, which gives a tigrad or a tessellated fundus. Next, there is a temporal crescent. Because of the differential, there is the elongation of the nasal and the temporal sclera. So there is a dragging of the sclera temporally, and there is a loss of this Brooks membrane opening, or where is the loss of this choroid at the temporal aspect of the disc. What we see crescent, that is a Blair sclera temporal to the disc. So this is a tessellated background fundus of a 28-year-old male who is having a minus 18 diopters of refractive error. However, is maintaining a very good vision of 6/9, 6/12. But when we saw this fundus, there was like a reddish lesion. Initially, one moment I thought it may be some myopic CNM. Then I did a OCT. It was normal. What we saw was just a altered foveal reflex. So posterior staphyloma hallmark is there is a stretching of the sclera. So there is something called a second curvature that develops in the posterior portion of the eye. Okay, the radius is different from the surrounding eye wall. So this is a optos imaging showing a posterior staphyloma. We can see there is a like cupping of the posterior sclera, and there is a demarcation you can see from the rest of the fundus. This is a 3D MRI showing the bulging. Coming to the chororetinal atrophy, there is a diffuse atrophy where you can see there is a grayish white of the fundus, and there is a focal chororetinal atrophy. There is a loss of this RP along with the choroid, causing a appearance of the bare sclera. Then coming to the lacquer cracks, these are nothing but these are a linear yellow lines, yellowish white lines which are seen the posterior pole. These are nothing but the breaks in the Brooks membrane because of the stretching. So usually may be associated with a hemorrhage in a fresh lacquer crack. So we need to observe these patients for development of a CNV. Then fugue spots, these are nothing but the proliferation of the RP around the neovascularization membrane, which is nothing but in healing response. We see an hyperpigmented reddish or a blackish lesion. So myopic CNV is an important cause of vision loss in these myopic patients, especially in high myopia. 10% of these patients will have a CNVM. 30% eventually involves the other eye. So any recent onset of vision or a metamorphosis should be taken seriously. So usually develops type 2, that is a subretinal CNVM, responds very well to an anti-VEGF. Okay, but these are the few prognostic factors. Whereas increasing age and atrophy, worse vision acuity presentation, a suboval location, larger the size of the CNVM, and a delayed hemorrhagic resolution can have a poor prognosis. So this is, you can see there is a red lesion in the macula. On FFA, you can see a leakage, and OCT showing subretinal CNVM complex, which is very well picked up the vessels on the OCT angiography. So this is a case of a type 2 CNVM.
Again, we lost
We
your.
cannot see. We cannot see your presentation. You need to share screen.
Sir, just now you lost, sir. How is it?
Just now we lost it.
Just now, you can just log back.
Yes. Can you see, sir?
Yes.
So this is a case of myopia with having a CNVM. On OCT, you can see subretinal fluid with hyperreflective material. So OCT angiography is showing a beautiful neovascularization in the outer retina. So this is a pre and post anti-VEGF. You can see the beautiful resolution of this macular thickness and also the resolution of the regression of the new vessels. So this is another case of a myopia with having a CNVM with a subretinal.
Again, we lost Ravi. Yeah.
Can you see, sir? Maybe
Yeah.
because of the internet. I'm really sorry, sir, for that.
It's on, yes.
Yeah. So this is, and usually these patients with CNVM, they go into macular atrophy over time, even with the treatment. So thermal laser PDT are history now in the CNVM management. They respond very well to anti-VEGF, and we need not give a loading dose like an age-related, ARMD-related CNVM. So 1 or 2 injections do the best, and usually we do is a PRN dosing. So what is the natural progression of this myopic maculopathy? Usually tessellated bag fundus, once they cross this stage, they usually progress faster from diffuse to patchy atrophy to total macular atrophy. And there is also this lacquer cracks can develop into a neovascularization. Overall, there is 40% chance of progression during the follow-up of these 12 years, which is given by Hayashi et al. Then coming to an important, one of the finding is myopic tractional maculopathy, which affects in 9 to 34% of these myopic. The main hypothesis is that there is a posterior bulging of the sclera, which is pulling the retina, and also vitreous is pulling anteriorly, along with some an additional ERM, which is pulling tangentially. So it is going to cause a stretch or a split in the retina, causing what is called as foveoschisis. So this is one case of a very 60-year-old female with axial length of 34 mm. You can see a posterior staphyloma with a myopic foveoschisis. Vision was very poor and it was observed. So then this is another eye having a very good vision and having a follow-up of maintaining vision over the last 4 years. So no need to do any surgery for such cases, because doing surgery in these eyes is very challenging because these are longer axial length. Sometimes reaching the instruments onto the macula is very difficult, and also the vitreous PVD induction and removing the peripheral vitreous also very challenging. So we should be very careful. This is the case of an unilateral myopic tractional macropathy. You can see there is splitting of the retina right in the nerve fiber layer, and there is a separation of the ILM from the rest of the retina in the left eye. So this is another case where there is a myopic foveaceous in the right eye and a scar. There is a macular scar in the left eye. So coming to the foveaceous, so these are usually measured of case of an outer retinal chassis, but it can occur at any layer. Okay. So this is a classification right from extrafoveal, foveal, and macular involvement. Okay. So these are the different gradings. So this is a natural how a foveaceous can progress from a foveal to extrafoveal to involving entire retinal detachment and involving the macula. What is the management of this MTM? There are two important therapies, that is a macular buccal and a pars plana vitrectomy. Each one has its own pros and cons. Okay, so we have to individualize, customize based on the case. Okay, so one can try PPV. It doesn't work, then we can try a macular buccal. But macular buccal is needs more skill and okay, and it has got its own complications. This is one of my case having a foveaceous in the left eye. So this with a vitrectomy, you can see how beautifully the chassis has resolved and patient vision improved. So this is after a core vitrectomy, we are injecting tricot to confirm the PVD. Once the PVD is induced, and after that we inject brilliant blue-green dye to stay in the internal limiting membrane. In this case, there was a fine ERM. So after I stained, there was not a complete staining of the ILM. So I had to again restain to re-inject to stain the ILM. So once I stained, I removed the ILM. So after that, fluid exchange was done, and SF6 was injected. There is something called fovea sparing ILM peeling, which we usually do in case of a macular foveaceous. Basically, we spare the ILM around the fovea and we peel in the macular area. Okay, so this is to prevent deroofing of the fovea, so that to prevent macular hole formation. So this is a case of a pathological myopia with a macular hole and a peripheral.
Again, we lost it. Yes.
Can you see, sir? So this is having a total retinal detachment with a choroidal detachment. So managed with internal procedure. You can see a pre-op OCT and a post-op OCT. Then coming to a dome-shaped maculopathy, this is nothing but a convex bowing of the macula in a pathological myopia. Okay, so usually they will have a very good vision. It is because of a relative localized thickening of the sclera under the macula in a highly myopic eyes. Subretinal fluid can be present, and rarely it can lead to a CNVM formation. Okay, so this is a case of a dome-shaped macula with a neurosensory detachment. So these are the indications for a vitrectomy in a macular foveaceous. So then macular hole, how does it different from a normal macular hole? Usually myopic macular hole lead to a macular retinal detachment in the because of the poor RP.
Again, your presentation is not visible, Ravi. Just after you showed the dome-shaped maculopathy with SRF.
Sir, really sorry, sir. I don't know why this is happening. So can you see, sir?
Yeah, this we can see.
So macular holes in myopia are not similar to idiopathic macular holes in a emmetropic eye because of poor RP function. So these myopic macular holes can have a subretinal fluid or SRF. Okay, and also the success rate of these myopic macular holes is lower compared to in a emmetropic eyes. So, and we have to do what is called as an inverted ILM technique in these myopic eyes. Okay. So this is a case of a not a very high myopia, low myopia. We having a full thickness macular voltage subretinal fluid. So this is a video. This was operated today itself after tricot assisted PVD induction. So BBG was injected, and I am doing an inverted ILM flap where we peel the ILM around the macular hole and fold it over onto the macular hole. Followed by fluid air exchange and gas injection. So, and this is if you one slide about the macular buckle. There are different types of macular buckles. I personally, I don't have any experience over this procedure. So, to conclude, myopic maculopathy is a very common morbidity in high myopia. 40% can have progressive rate. Careful examination is very important to look for a neovascularization or a foveosis or a macular hole. Because of the lack of contrast, because of the lack of this loss of RP and the chororetinal thinning, so it's very difficult to diagnose. A careful evaluation and OCT is very important, and especially a recent onset of vision loss or distortion of vision should be taken seriously. Timely management, diagnosis and management can restore the vision. Thank you.
Thank you, Dr. Ravi.
I'm really
Dr.
sorry
Ravi,
for the interruption.
No problem. It happens can happen to anyone. Absolutely no problem. Dr. Naveen, do you have anything to add on? Dr. Ravi, you can stop sharing your screen.
Yes.
Yeah, nice presentation actually. Myopic maculopathy is, especially surgically, is one of the most challenging. So one important thing is most of the time, even if it's a macular hole or a myopic foveosis, one thing as a tamponade is gas always does better than oil. That's something I definitely try. Even if we have patients coming from abroad who want to travel back, I insist that they stay at least for 4 or 5 weeks until when the gas resolves, because the results are much better. So that's the only care I take. Else, I think Dr. Ravi covered it wonderfully.
So do you have any
Thank you,
experience
Dr.
with
Naveen.
buckles,
Yes.
macular buckles?
No, I've never done buckles. Macular buckles.
So we'll move on to the next talk. So next we have a case presentation by Dr. Ruchi. Dr. Ruchi is a gold medalist from Kasturba Medical College, and she has a fellowship in vitreoretinal surgery from Arvind Eye Hospital. And she's presently working as a VR surgeon at Pragati Eye Hospital, Mysore. Over to you, Dr. Ruchi.
Good evening, everyone. Can you hear me?
Yes, ma'am.
Yes, visible.
So at the onset, I would like to thank KOS and Dr. Soumya for giving me this opportunity. I chose this case of PCV because it was a very challenging case for me, in the sense that the patient kept on coming back with recurrent symptoms, and I had to give multiple injections in a course of almost 5 to 6 years now. So a 63-year-old female presented to me in 2021 November with defective vision in right eye since 2 months. Vision in right eye was 618 and left eye was 69. There was history of intravitreal avastin taken outside all in 2018, and there was no follow-up since then. So fundus showed right eye PED with SRF, left eye showed QRP changes. Presumptive diagnosis of PCV was made, and patient was advised anti-VEGF. Patient opted for Razumab biosimilar, and two intravitreal injections were given, after which the PED decreased, vision improved, and SRF were resolved. Patient again presented to us in July 2022 with defective vision in right eye of around 618 parts. The OCT again showed increase in height of PED and SRF. Patient decided to take the same anti-VEGF as she responded before, and 4 injections of Razumab were given, although the patient did not come for a monthly injection. So they were given in a span of around 6 to 7 months. The patient was better and then lost to follow-up. Again, patient presented in September 2023 with defective vision in right eye. This time, patient had a drop of vision of one line up to 624 parts. She was advised aflibercept. So from September 2023 to July 2025, she received 8 doses of Eylea almost every 2 months. After receiving 8 doses of Eylea, patient presented in September 2025 with again drop in vision, and fundus showed orange nodule with orange subretinal round elevation with SRF, multiple PEDs and hard exudates as seen in the OCT. She was now advised Pegenex, and the 2 doses were given at 6 weeks interval. Last review was in March in 2026. The patient showed no hemorrhage, decreased PED height, and with no SRF. So these are the multiple OCTs which have been taken. The initial is taken after 1 dose of, 4 to 5 doses of. I have lost the initial 2 years of OCT because of my machine problem, but these are the last 3 years. So in this, the patient shows recurrence. These last two slides are after giving the Pegenex injection. Now patient is quite happy with the resolved PEDs and no SRF. So this is also a serial OCT of the disease process. Now we know IPCV was introduced in 1982. It was first considered to be a subtype of neovascular AMD. 50% of neovascular AMD in Asia are of PCV subtype. But why do we have to differentiate? Is because PCVs are very prone to non-resolving and or recurrence despite anti-VEGFs. So the main findings in PCV are presence of pachychoroid disease, and these patients do not have soft drusen or extensive drusens, which are usually seen in AMD. The main features which are present are the presence of polyp or VVN. So this is the fundus picture. Patient can also present for vitreous hemorrhage or breakthrough bleeding in cases of PCV. So the modalities of diagnosis, the gold standard till now was considered to be ICG, in which we could see the polyps and the presence of the vascular networks. Now, recently, there has been a study by the Asia Pacific Ocular Imaging, which wants to make OCT as the gold standard for diagnosing the PCV. This shows the features which can be seen on OCT are sharp-peaked PEDs, sub-RP ring-like lesions, complex or multilobular PED, a double-layer sign in which you can see a difference between the RP and the Brooks membrane, a thick choroid with dilated halar vessels, a fluid compartment which can be intraretinal or subretinal fluid. End-phase OCT shows a RP elevation, and fundus photo should show a orangish nodule with hemorrhage and absence of drusens. So any of the 4 features present on OCT, along with the end-phase and the fundus picture, they had seen that there was a sensitivity of around 94.6% and specificity of 92.9% in diagnosing PCV, even when we do not do a ICG or a OCTA. Now, OCTA shows again presence of polyps and presence of BBN. So the treatment basically which have been tried are anti-VEGF, a PDT, or a combination treatment. Every study showed that a combination treatment of ranibizumab with PDT showed very good resolution. Although with the advent of aflibercept, the studies have shown that aflibercept monotherapy is also good enough without combination with PDT. So my main questions are, is it necessary to do a ICG and OCT in PCV cases? Because I don't have a OCT and I don't have ICG. And what is the first line of treatment for PCV cases? Should we go directly for Pegenex and Eylea, or it can be managed with ranibizumab? And what is the follow-up regimen? Thank you.
Thank you, Dr. Ruchi. Dr. Muralidhar sir, do you have any points to add to this? I also invite the other panelists to contribute if you have something to add on to the presentation.
Yeah, but why don't you ask the other panelists to give their comments? Then I will.
Yes, absolutely. Anybody else here who would like to pitch in for this case?
Yeah, regarding the first question on whether ICGA is absolutely required for diagnosis of PCV, definitely it's not that it is absolutely required with the current OCT understanding. We have understood OCT features of the PCV better. Yeah, definitely it helps, particularly in cases where there is a extensive subretinal hemorrhage, a hemorrhagic PED. We may not be able to localize the polyp, but that again is not absolutely essential for management in the current era where anti-VEGF remains the treatment of choice. But I definitely do consider ICGA. If the patient is willing to get it done, I do consider an ICGA to do a baseline one to establish the diagnosis. And particularly, I would consider when it is an extramacular one. So where I would consider a laser or sometimes even in PHCR, the peripheral exudative hemorrhagic chorioretinopathy, when it's in the periphery, there would be a subretinal hemorrhage. Rather than doing cryo to the entire lesion, just localize it and do a cryo to only that area. So that is what I would consider. But yeah, this is again not I didn't had ICGA for the past 6 years. I used to manage all my cases since the last 2-3 years. So I'm doing it. Yeah, definitely helps in certain scenarios. As I was mentioning, when I am considering a laser, yesterday I did one surgery, a VMT with the peripheral exudative hemorrhagic chorioretinopathy. So in that, the polyp could be seen as a separate lesion and I could only treat that area. So ICG does help, particularly in those cases, but the current OCT understanding is so good that we can diagnose PCV in most of the cases.
And what about Opta, sir?
Opta, the newer generation Opta, particularly I should not no financial interest, but the Zeiss Angioplex Elite and even the Intalite Dream OCT, the polyp detection is pretty high. We can detect polyp in close to around more than 90% of cases in these. The older generations one, which even we are using, the polyp detection is pretty low. We can identify the branching neovascular network. As I mentioned, the cases in which there is extensive subretinal hemorrhage, hemorrhagic PEDs are the ones in which we'll not be able to identify. But again, considering the current line of management being anti-VEGF for the macular lesions, mostly we end up treating with anti-VEGF and identifying that particular polyp may not really have a role at the current practice. Again, I PDT, for us, it's there's no, we are not doing PDT since the past many years due to non-availability. A few centers were still doing, but for them, yeah, it would definitely help.
True, because more than OCT angio, we have enough sign on OCT, you can definitely pick up. So unless you're planning for an PDT, if it's an extrafoveal where you are going to try focal laser and you are going to inject anti-VEGF. So, of course, if you are in a setup where you are limited by availability of ICG, definitely you can base your treatment based on the OCT itself. Even for the extramacular lesions also, you can do OCT over there. It's very typical. Clinically and OCT, you just don't need, still you can do a focal laser. It's good to have an ICG, but that's not a limitation in case if you don't have to manage that.
I think
You're
I see.
muted.
Yeah. Please go ahead.
Dr. Soumya, ma'am, you're muted. You are trying to tell something.
I'm so sorry. I was asking if we can move on to the next talk, but I think sir had a point to make.
You can. No. I think you can. I think the points have been well covered. We can diagnose PCV based on clinical and OCT features. I think Ruchi has already highlighted some of the features given by the Asia Pacific PCV study group. So ICG is a good thing to have. If you are in doubt, ICG is a good thing. Otherwise, it's not necessary. And I'm not really enthused by OCTA in PCV, at least as Pradeep said, you need to have really the very good angioplex or the intralight, that kind of a OCTA to really detect polyps. Otherwise, the regular OCTA is, it's difficult to pick up the polyps on OCTA.
She
And
had
so
one
what
more
about
question, Ilya and Pajanex. That
Yeah.
was her second question, right? No, for that definitely
Eyelia
yeah.
Patch.
Answer is yes. I mean, sir, you
If
can
cost is not a factor,
Yeah,
Those are
you
the
see, if the
conditions.
patient is responding to Eyelia, I would continue Eyelia. Those patients who are not responding to Eyelia, then I switch over to either Paginex or Vabysmo.
and sir,
That
like
won't be
this
my,
patient,
definitely Paginex would not be my first line of treatment. I have burnt my finger, developing a patient developing an intraocular inflammation after I gave the second injection of Paginex. So it is reserved for eyes that are resistant to Eyelia. Probably now that Vabysmo is available and it is shown to produce good results in the Selvin study, that's another drug that can definitely be tried in these patients.
So I invite Dr. Vishma next to present her case. Dr. Vishma is a consultant in vitreoretina at Narayan Nethralaya with over 10 years of experience. She has a fellowship from Arvind Eye Hospital and is an expert at managing diabetic retinopathy, vascular occlusions, and performing MIVS for retinal detachment. Over to you, Dr. Vishma.
Thank you, Dr. Soumya ma'am, for this opportunity. I share. Is it visible?
Yes.
Okay.
Yeah, your screen is visible.
Yes, sir. So now, today I just present a case about a 33-year-old male who had an erratic behavior, and he presented with defective vision in his left eye, and is at the time of presentation, his vision was 636. And he was also on inhalation steroids. And when we did a clinical examination and following with the OCT, we saw that there was a serous macular detachment, and we concluded that it is central serous chorioretinopathy. So since this was the first time he presented, we asked him for a lifestyle modification and to stop inhalation steroids. Now, the patient, after that, he did not come back. He came only after 1 year with, again, recent onset of loss of vision. His vision was 6/9. And since this was the second attack, we went ahead with FFA ICG. And what we saw was a subfoveal active leak, ink blot CSCR leak. And the options we had was PDT, and or we could just observe and do a lifestyle modification. Since PDT was not available, we just observed. And also the patient, after 1 month, the patient came back with persisting subretinal fluid. Now this time we strictly told him to reduce the stress level, do a lifestyle modification, and also started him on tablet eplerenone, 50 mg daily. And 1 month later, he did show a drastic improvement. His vision was came back to 6/6, and we still continued with eplerenone, 50 mg. Now, even after 14 months, we still continued with the eplerenone, and he was doing fine. Now, but after 2 years, when he came back, he had already stopped the eplerenone. He did tell us that he had a very high stress level because of his job. And since this was again another attack, we ended up with FFA ICG. And this time it showed an extrafoveal leak. So we went ahead, did a focal laser to this extrafoveal leak, restarted him on eplerenone, and advised for a lifestyle modification. Now, the SRF accumulation in the retina can be simply explained with the tap drain model, the tap being the choroidal hyperpermeability and the drain being the management by the RPE. And the collection of the SRF is because of the simple mismatch between the excessive choroidal leakage and the decreased RPE clearance. And there are certain drugs which would help in working against the corticosteroid pathway, that is the inflow pathway, like the mineralocorticoid antagonists like the eplerenone and the spironolactone. Here, if we see, usually the cortisol binds to the mineralocorticoid receptors and increases the choroidal permeability. But when we start the patient on eplerenone, the eplerenone competitively binds to the mineralocorticoid receptors and inhibits the cortisol, and as a result of which there is no increase in choroidal hyperpermeability. And as a result of which the eplerenone acts on the inflow pathway. But there are some RCTs which have shown that this is a big RCT in UK which conducted and did show that eplerenone is not superior for improving the BCVA in people with chronic CSCR after 12 months of treatment. We had our own publication where we did eplerenone with observation in case of acute CSCR, and a few takeaway points were from the study that once we start the patients on eplerenone, there is a faster resolution of SRF and faster improvement in visual acuity, and there is a reduction in the subfoveal choroidal thickness in both eyes, and it reduces the recurrence of the SRF in the affected eye. But we have to avoid eplerenone usage in unilateral or bilateral chronic cases of CSCR, where there is a dysfunction of the RPE, and if there is a pachychoroid spectrum, and of course, if there is a renal disease. Now, eplerenone is a mineralocorticoid receptor antagonist, and along with the lifestyle modification, it can help in prevention or preventing the recurrent attack. Now, whenever we start the drug eplerenone, we always start with the half dose for 1 week and then increase the dosage to 50 mg. And always we get a serum electrolytes and kidney function test. And if normal, we continue with the drug. And blood investigation has to be done once a month. And till when do we continue this eplerenone? We continue along with the lifestyle modification for a longer time till it allows the elevated cortisol levels to reduce and come back to normalcy. And the eplerenone blocks the mineralocorticoid receptors. And when do we stop the drug? Whenever there is a completing a resolution of the subretinal fluid, prominent, thickened, and dilated choroidal vessels returns to normal, which we have to document on ICG. And if there is any adverse effects of the drug, we stop this drug. Thank you.
Thank you, Dr. Vishma. That was very interesting. Do we have any other inputs on this case?
Ma'am, what is the percentage of this patient responded to eplerenone, ma'am, in your study?
Sorry, sir?
How many of these patients responded to that?
In this study, it was all, we collected the data about acute CSCR who presented with less than 3 months duration. So we had 29 eyes for observation as well as for the treatment.
No, how many of them responded to the treatment?
So almost amongst 29% did respond to this 29 eyes. All the eyes with treatment who were on treatment with eplerenone did show response at the end of 3 months to 4 months.
Because some studies say it's not going to work. Or
that's what the thing is. See, even with the natural course, what the study she quoted from the UK, that Andrew and non-placebo, these patients without that also they would have, because all these acute CSR with lifestyle modification, they are known to improve. It is like that. And also, if you look at the mechanism of action of why steroids cause CSR, there are 8 mechanisms which have been proposed. So it may address only one aspect of it. Okay, so that is also a doubtful role. I don't know. Muralidhar sir can comment. Do you use eplerenone, sir, for CSR?
I mean, I don't use. I refer to Dr. Manjula, who, in case if I feel that the patient needs eplerenone, she's the one who handles these cases. Although the VC trial showed that eplerenone is of no use, we do have some anecdotal cases where it seems to have helped. So I don't think I would declare that it's a useless drug. See, we don't have anything else to offer to these patients. So whatever difference it can make in some patients, I think we can use it and see. So I still feel it has a role, but at this point of time, we don't have anything else to offer to these patients. So
I like your system, 1% to handle all CSR. We should follow that.
No, it's easier that way. So see, they gain experience and they're able to manage the patients better instead of I seeing two patients and treating them up and on. Hemant seeing two patients. At least I say let one person handle this particular treatment so that they gain experience and ultimately patient benefits that way.
I think serum electrolytes needs to be monitored whenever you order and because initially physician will never say no to eplerenone. They do give clearance, but in between they're prone for other things, because arrhythmias and all have been reported with these kind of drugs. So I think better we ourselves monitor the serum electrolytes. That is better. Because physician will never say no to this.
See, only message I have for a general ophthalmologist is that when we were postgraduate, CSR was a simple disease. So as we became retinal surgeon, it became a complex disease, and now it is one of the most challenging diseases for us to treat because of its variety of the presentations and all that. So I think CSR cases have to be referred to a retina specialist for management. If they are not resolving within the normal time of 1 to 3 months, better to refer to a retina specialist for management because it needs probably multiple OCTs and treatments and systemic steroid intake is a very important thing because we have had patients who had received multiple injections, but ultimately when the patient stopped the usage of steroids, patient did so well, patient regained almost normal vision, after having been having a steroid-induced CSR for almost several months. So systemic lifestyle modification and stoppage of usage of steroids either in the nasal inhalation or skin cream or any other way is a very important thing.
And just to add, Dr. Soumya, I think minoxidil is again a very largely abused drug. We don't tend to, because some of them, due to a stigma, they don't really express. But usage of minoxidil is a very common, CSR is a very common side effect of use of minoxidil. And it's available over the counter, and it's not most of the time prescribed by a doctor. Someone who's experienced it or used it before tells it to another friend, and it's just used. And these are the patients who come up with, end up with CSRs very commonly.
Thank you. So I think we've come to the end of our webinar. Is my screen visible?
Yes, very much visible.
Okay. Thank you. I seem to have lost control.
You're saying it's time to say goodbye, huh?
Yes. So thank you very much. Thanks to all the speakers, panelists, and Dr. Muralidhar for joining in. A big thanks to KOS for letting us put this together, and Microlabs Vision Division for all their support, especially Mr. Navneet, Mr. Karanveer. You've been very supportive. Thank you so much for the platform. And I think we can stop our live share. Before I stop, I just wanted to address one question that an audience had posted. I think this was regarding the case of macular hole, which was turned out to be an RD, or the CSR that turned out to be an RD. And you mentioned that it's important to do an IDO and a full examination of the periphery of the retina as well. So I believe this was related to that, and they wanted to know if a B scan should be done at this point. Would anybody like to address this?
See, a B scan in clear media doesn't make any sense to me. If you can see with the indirect, definitely you're not going to pick up anything more on a B scan. B scan is useful in the hazy media to
Right.
pick up any detachment. Yes.
Okay, so I think this addresses their question. So we will call it a day. Thank you very much again. Thanks to all speakers for making time, Mr. Navneet and Microlabs as well. And hopefully we will see you all at the next webinar. Thank you.
Thank you all.
Thank
Good
you.
night.
Thank you. Thank you so much.
Good
Thank
moderation.
you, Dr. Soumya. Thank you.
Good night.
Bye-bye.
Thank
Good
you,
night.
doctor. Thanks a lot. Thanks to everyone.
Thank you, Mr. Navneet.
Yeah. Shall we close it?
Yes,
Yeah, yeah.
please.
Yeah,
Yes.
fine. Thank you, sir. Thank you.
Nicely done, Soumya. Thank you.
Yeah.
Thank you. Thank you very much. Bye, sir. See you, sir. Thank you, Ravi, sir, for joining in as well. Thank you. Bye.
Bye, Soumya.
Bye. Bye.
Thank you. Good night.